طيب السلام عليكم. بما أننا we reached the second part of the skin lectures إن شاء الله هذا part will be very easy. It's also self-explanatory and if you can read this part by yourself you can also understand it. So the first part is the dermatophytosis and the candida infections. The first specific infection is the diaper dermatitis. So say for example that you are a dermatologist and a mother presents to your clinic and she has their child and she tells you that her child has a specific diaper rash in the groin region. The first thing that you should suspect is actually a candidiasis. And why a candidiasis? Candida is a fungi, and that fungi loves places that are humid. So if you have that child who are not changing their diapers very frequently, or who are not really having showers that frequently, they will eventually grow a candida infection in the groin region. So candidiasis is a very important cause of the diaper dermatitis. It's red in color and it has these satellite lesions that I'll just explain in a moment. What are the treatments? So I've explained that this is primarily due to the humid nature that might arise from less frequent diaper changes. So if you want to treat it, you need to keep the child hygiene as it should be. You need to do frequent diaper changes, antifungal cream, since Candida is a fungi really. You need to do barrier cream zinc, which is also primarily used for the diaper dermatitis. So these are the satellite lesions. And when we say a satellite lesion, we really mean a lesion that is primarily and those are known as satellite lesions. And why are they known as satellites? The name might clue you into why they're named as satellites. These are lesions that start proximally and they end distally as satellites, right? As cone lesions. Imagine if this is kind of the Earth and these are satellites that are surrounding the Earth, and thus the name satellite lesions, right? Pretty easy. And they're also red in color. And then there's the Tinnia capitis, right? And the Tinnia capitis is actually known as the ringworm, except that it's not actually a worm. It's known as the ringworm because it forms this ring-like structure, right? It forms this ring-like lesion when it infects a person. And Tinea capitis is actually named according to the area where it actually infects. So if it infects the head, as in this case, it's called Tinea capitis. If it infects say, for example, the trunk, you would call it Tinea corporis. And then this is actually tinea is the cause for the athlete's foot. If you might have heard about it before, you probably have heard about it. So tinea is actually the cause for that specific disease. And now this presents with an annular scaly plaque with occipital lymphadenopathy. Why is there occipital lymphadenopathy? Well, it's a tinea, it's an infection. So adenopathy would arise with an infection, right? Why is it annular? And annular, what we mean by annular is that it forms a ring, right? So this is a ring. Thus the name ringworm. So it's an annular scaly plaque. Why is it scaly? It's rough on the surface, as you can imagine, and as you can see here. And it's a plaque, and if you guys remember when I said at the beginning of lecture 1, I mentioned that the plaque is basically a raised lesion, right? So this one is raised, you can see the raised spots, and it is greater than 1 centimeter. Of course, this is definitely greater than 1 centimeter. For the tinea capitis, right? So the tinea capitis should be considered in every child with a scaly scalp, as the infection is very common. It's very, very common actually. And it almost like, as I've mentioned that tinea could cause the athlete's foot, it could cause the tinea corporis. But if you see tinea capitis, that tinea capitis is primarily due to, the tinea capitis is primarily due to an infection that occurs in children, right? So if you see a child with tinea, they're probably having tinea capitis. And you should, the course of infection is very long, right? So griseofulvin is a drug that is primarily used to treat this type of tinea, and it's very long. It can go as long as 8 weeks. So we need to confirm by mycological assessment that the child actually is suffering from tinea capitis and not any other type of infection. And then let's go on. So the tinea capitis could actually present as inflamed and non-inflamed lesion, right? And the inflamed lesion would present with typical signs of inflammation, right? So you could see the pustules due to the inflammatory, the ongoing inflammatory process. And then for the non-inflammatory lesion, you would see that while it's a coin-like lesion, there wouldn't be the pustules that would arise with inflammation, right? However, you would see that the hair would fall. And then eventually, if you treat actually the illness, the hair would grow once again. So it's not permanent. However, in the inflammatory process, when you have an inflammatory tinea capitis, the inflammation could be so severe that eventually the child would end up with permanent alopecia, right? So you have to treat it very, very promptly if you suspect tinea capitis. And then, of course, one thing that is specific about the inflammatory type of tinea capitis is known as a chirion. And a chirion is an abscess that is caused by a fungal infection, right? So since it's an inflammatory lesion, it would eventually result in an abscess, and that abscess is known as a chirion. And this is a severe form. So in the severe form, the deep form of tinea capitis, you would definitely see a chirion. And for the tinea capitis, the inflammatory, you would use an antifungal, right? So you would use griseofulvin, just like we've discussed before, just like in the regular tinea. However, you would also use a prednisone. And what's prednisone? Prednisone is basically a glucocorticoid. You would use that if you have inflammation, such as the case in the chirion in here that we can visualize on both of these images. So use prednisone in order to limit the inflammation that might arise. Now, what is this? So this is a disease that is quite interesting, to be honest, because you can see that these lesions in here are not actually the same. So these lesions are hypopigmented, and when I say hypopigmented, then I mean that when we compare it to the normal skin, these appear to have less pigment, right? They appear to be whiter. However, when we compare this one, this is hyperpigmented. When you compare it to the normal skin, these are darker in color, right? So this would clue you into something that is known as tinea vesicular. And tinea vesicular, as the name might suggest, and as the doctor has mentioned during the lecture, vesicular really means متعددة الألوان, and that's why you would see hypo and hyperpigmented rashes on someone's skin who's infected with tinea vesicular. Now, tinea vesicular is very common, right? It's a superficial infection. And why is it very common? It is common because the causative agent for tinea vesicular actually is part of the normal flora of our skin. That is, you all actually have the causative agent, which is known as Malassezia furfur, living on your skin. It's just that you have not yet been exposed to certain factors that might cause this agent to cause the illness that we can see here, which is tinea vesicular. So it was previously known as Pterosporum or bacular, but it's now known as Malassezia furfur. But again, for the sake of the exams, I think you would have to memorize this name in here. So it's a saprophytic yeast, and when we say saprophytic, that is, it actually decomposes or lives on the dead matter on the skin, and it's part of the normal skin flora. So the tinea vesicular lesions could be hypopigmented, light brown, or salmon-colored macules. So they are متعددة الألوان once again. And why are they متعددة الألوان? I think it's very important that we understand rather than memorize something. It is because of the pathophysiology of the tinea vesicular, of the causative agent. The causative agent could result in lipid degradation, and it could also result in the reaction against the organism. And when it actually results, let's just discuss first thing the lipid degradation. So it actually accumulates on the skin. It causes the lipid degradation, and once you have lipid degradation in the skin, you're going to have toxic material. And these toxic material eventually could harm the melanocytes. If you recall, these are the cells that actually produce the melanin. If you don't have melanocytes, you don't have melanin, you have hypopigmented lesions. On the other hand, when you have a reaction against the organism by the immune system in your body, you're going to have accumulation of more cells, and thus you're going to see these hyperpigmented lesions. So those are the two reasons behind the hypo and hyperpigmented lesions that are specific for tinea vesicular. There is a fine scale is often apparent, especially after scraping. So if you scrape the lesion, the hypo or hyperpigmented lesion, you would see a fine scale that is underneath that lesion specifically. So and then these lesions are actually typically small, but frequently coalesce. As you can see in here in this image, these lesions are actually pretty small. They're not actually that large, right? So these are small lesions, small lesions, small lesions. Eventually, these lesions, once you have a lot of lesions, just like in here, right? You have a lot of lesions, they coalesce with each other and they present with this large lesion that is surrounded by these small lesions that are yet to coalesce, right? So this is on Tinnia vesicular. Uh, Typically, the disease is found on the upper trunk and the extremities and is often less often on the face and the intergenous areas. And why is that? Once again, so the disease actually arises when someone is exposed to a humid area, to a hot humid area, and so the upper trunk and the extremities. So those are the areas that are usually very humid and are usually also exposed to heat. Whereas the face, which might as well be exposed to heat, is not as humid as the upper trunk or the back, for example. And so the usual presentation to your clinic would be someone who would, for example, be a landscaper or someone who works in a labor-intensive kind of job where they would be working in the sun for long hours and they would eventually get tinea vesicular. So most patients are usually asymptomatic. Some of them have mild pruritus. And the diagnosis of tinea vesicular is confirmed by microscopic examination with 10% potassium hydroxide. And potassium hydroxide is a strong base, right? And it would dissolve all the proteins. So if you scrape the skin and get the area that is actually hypo or hyperpigmented, you would eventually get the causative agent. But what would potassium hydroxide do is that since it's a very strong base, it would damage all the surrounding cells and the proteins surrounding that specimen. So you would only be able to visualize the causative agent in the which is melasthesia for tinea vesicular. So the differential diagnosis, seborrhea, eczema, psoriasis rosea, and secondary syphilis, primarily due to the a very similar presentation. The treatment, again, includes topical antifungals. Oral antifungals can be used for more extensive disease. So ketoconazole you could use. So fluconazole and itraconazole as well. These are all antifungals. And to make it easier for you guys to memorize them, these all end up in the zole, right? They all end up in the zole suffix. And the itraconazole is quite interesting because the causative agent is actually a dimorphic fungi, and the itraconazole specifically is an antifungal that is used for dimorphic fungi. So let's move on to the viral infections. So the first viral infection we're going to discuss is known as Moluscum contagiosum. And Moluscum contagiosum is actually a viral infection that appears as these flesh-colored lesions, right? So these are the same color as the surrounding skin. They're not any different than the surrounding skin. They're not erythematous, right? They're the same color. Again, here, same color, and here, same color, right? Um, and these exactly, if you would view them more closely, you would see that these are actually umbilicated. There's like some kind of umbilicus, that, just like the one we have in our body, that is in the center of this lesions that are observed with Molluscum contagiosum. So it's caused by a DNA pox virus, and this is the same pox virus that actually causes cowpox, right? So they're from the same family. And then it's a common viral disease with higher incidence in children. So this is usually observed in the summer, in the summer or hot months, because it primarily initiates this replication of the virus, and primarily because of the fact of how this disease is transmitted from one individual to another, which is by the fecal oral route. And the significance of this will be discussed later. So it's most common, higher incidence in children, most common in children aged 1 to 10 years, and can affect any area of the skin, but it's most often on the trunk, the arms, the groin, and the legs. And this disease could actually also affect the elderly, could also affect the middle-aged. And when it affects them, it's usually caused by sexual transmission. And once it causes sexual transmission, um, this sexual transmission would eventually result in a single lesions, right? So in children, you would see a lot of lesions, but in adults, it's more of a single lesion rather than a number of rather than multiple lesions as observed in children. So here is the umbilicated lesion, and again, same color as the flesh surrounding it, right? And again, the umbilification here, the umbilication. The molluscum contagiosum is a self-limiting condition, so you wouldn't need to treat it. You would just need to reassure the mother or the father or the adult person that it would eventually it would eventually disappear. It's benign, usually resolves spontaneously. You might do some intervention, and that is if you want to speed the resolution, if you want to reduce the self-inoculation and the symptoms and limit the spread of the lesions themselves. And so what is this? This is actually, and apologies guys, but I've mentioned here that this is transmitted by fecal oral route. Please disregard this information. Uh, just please just disregard it. So what is this? This is actually known as warts, and warts are actually caused by HPV, and I think we've studied HPV extensively in the last block, right? So all of these are warts, and as we have learned, these are all warts that appear with a cauliflower appearance, and these are known as plantar warts, and this is primarily because they happen on the sole of the foot. So the common warts, there are three main types of warts. There's the common wart, the plantar wart, and the plain wart. And the name would really clue you into each type and how would you differentiate between each of which. So common warts develop as smooth flesh-colored papules, right? So they're flesh-colored papules, and they enlarge, and they eventually show this characteristic hyperkeratotic surface. And what is hyperkeratosis? Hyperkeratosis is when you have an increased number of the cells of the upper surface of the epidermis. So you would see that these are the cells are kind of proliferating way too much on the surface. And this is what we mean by the hyperkeratotic surface. And of course, of gross thickened keratin, since they're of the upper epidermis, on which keratin overlies. The plantar warts, right, on the plantar surface, so plantar, which is sole of the foot, so these occur in the sole of the foot and can be very painful. Now, all of them can be painful, but this one specifically is painful because when you walk on your foot, the pain would become much more pronounced. So usually the patient would present and they would be saying that the lesion under the leg is really painful, and that would clue you into plantar warts. Plain warts, they're, as the name might suggest, plain, so they're flat top papules, and they're typically scattered over the face, the arms, and the legs. So here we can see the warts, and again, warts, and all of these are warts, of course. And something interesting about warts, or about this condition specifically, is Kubner phenomenon. And this Kubner phenomenon is not really specific for warts. So we can also observe it in Turiaceae vesicular, we can see it in vitiligo, we can see it in warts. And what happens in the Kubner phenomena is that when you scratch the surface, right? So if you have an injury and you would scratch that injury, or for example, if you would scratch the lesion by yourself, or you would have an injury that would result in the scratching of the lesion, you would have a rash that would go along the surface, right? It will be more of a parallel rash to the surface that it's been compromised. Again, so these are as we can see here, these are rough topped papules, and we can see the hyperkeratotic surface, a lot of keratin that is being produced on the surface. You can see that this is actually we can see that this is actually the common wart. That is because it's flesh colored and it's also smooth, and it enlarges and develops the hyperkeratotic surface. And then also we can see that these are a lot of warts, and the doctor has mentioned actually that this specific kind of wart is very difficult to treat due to one reason or another. And then this is the verruca plana, and this is plana because, as we've said, this is flat, right? And we can see that it's actually flat, right? It's not raised lesion, it's flat on the skin itself. And then we can see the Kubner phenomenon in here, and this was primarily probably caused by scratch of the lesion, or by the fact that maybe due to one reason or another, they had a compromise of that specific area of the skin, which resulted in the phenomenon. And then the verruca vulgaris, we can see here the vascularization that might be caused inside of the verruca itself. So since these are actually, these are not dead, these are actually living areas in your skin. So once you scrape it off, you would see that the vessels have actually been able to penetrate through and be able to supply blood to these warts that are seen in here. And then, so the cutaneous warts, for the natural history, they're caused by HPV, and HPV infects the epithelium of the skin. Specifically, it infects the bassalis layer of the skin, and it also infects the mucous membranes. It mostly, and this is very important actually, not in explaining only the warts, but also all of the other conditions that might arise with HPV. So HPV, we know that it can cause laryngeal carcinoma. Why laryngeal carcinoma? Laryngeal carcinoma because in the larynx you have a specific area that is actually that has a squamous epithelium, and that area specifically is susceptible to being infected by HPV. Again, when you have the vulvar carcinoma, right? So HPV can also cause vulvar carcinoma. It can also cause cervical carcinoma, as we already know. And these both are lined by squamous columnar it's also lined by squamous epithelium. And so these become very important in understanding the effects of HPV on the body. And then the cutaneous warts most commonly arise in children and in young adults. And they're typically actually caused by HPV 1 through 4, so 1, 2, and 3, and 4 are very important to remember for cutaneous warts. They're most commonly observed by research that was done. They were most commonly observed among handlers of meat, poultry, and fish. And the predisposing conditions include atopic dermatitis. So I've mentioned before that any compromise on the skin would result in further infection. Atopic dermatitis could increase someone's susceptibility to getting cutaneous warts, and any condition in which there is decreased cell-mediated immunity. Why? Because if you don't have cell-mediated immunity, you wouldn't be able to clear off the HPV infection, and thus you would have the cutaneous warts eventually. How would you treat the wart treatment? You could treat it either by vitamin C, right? So very simple treatment, or you could treat it by cryotherapy. And what is cryotherapy? Cryotherapy is when you basically have this wart and you make this wart very, very cold, like extremely cold. That is, it becomes that it ends up actually that from due to it being very cold, you would be able to scrape it off eventually. However, this is a very painful treatment. And so if a child actually gets infected with cutaneous warts, you wouldn't do cryotherapy. You would either do vitamin C, or you would leave them to resolve spontaneously. So many warts can resolve spontaneously. Treatment in the children should be simple, effective, safe, and relatively painless. So do not go for cryotherapy in children. Topical salicylic acid, and salicylic acid is really just and it's really just another name for another complicated name for vitamin C. So topical salicylic acid should be regarded as first-line treatment for cutaneous viral warts. Cryotherapy is no better than topical salicylic acid, so don't think that because you're going for vitamin C that this is less effective. It's just as effective, and so you shouldn't just you shouldn't just disregard it from the list of treatments that you might have. Um, Again, the doctor has mentioned here that cryotherapy is best avoided in young children due to the side effects of pain, swelling, and blistering are excessive for a benign self-limiting condition. So this is a condition that would eventually resolve, and you don't want to cause all of these different effects for a simple condition such as this one that might eventually resolve on its own. So the hand, foot, and mouth disease, again, the name can clue you into the disease itself. So this is a disease that arises on the hands, the foot, and the mouth, right? And thus the name hand, foot, mouth disease. So here you can see these vesicular lesions, right? So they're kind of like vesicles, vesicles. And here they're on the hand. Here they're on the sole of the foot. Again, vesicles on the sole of the foot. And here they're on the mouth, right? And in here specifically, you can see these gray vesicles, and surrounding them, you can see this erythematous space. And erythematous space is just a fancy name for a red-colored base surrounding the gray vesicle, right? And this is caused by Coxsackie virus A and B, right? So Coxsackie virus A and B are very important causative agents for hand, foot, and mouth disease. So this usually arises on the hands, foot, and mouth, as we've mentioned. The lesions could be maculopapular, so they could have more than a single presentation. They could be maculopapular, roseola-like, they could be urticarial, but most commonly, you're going to observe the vesicular lesions on someone infected with the disease. So the usual presentation is that the lesions would start erythematous, and they would start small, and they would start as macules and papules. And macules, as we've mentioned, those are surface lesions, whereas the papules are raised lesions. They would eventually turn into superficial gray vesicles on an erythematous base, as we have seen here. See, those are all actually gray vesicles, and they're surrounded by the erythematous base. So this is probably the second phase of the infection. And then eventually some may ulcerate, leaving superficial scabs. You would have the rash for 2 to 7 days. And since it's an infection, you would have fever, you would have malaise, you could also have abdominal pain, right? And you could also have a sore mouth. Why would you have a sore mouth? It's because the infection really occurs in the mouth. You would have mouth lesions, and thus the sore mouth. And I think the best explanation, or something that I like to remember for the abdominal pain, is that the Coxsackie viruses are actually transmitted fecal orally. So I like to remember and know if someone actually gets the Coxsackie virus via fecal oral transmission, they probably got another infection that also caused their abdominal pain. And I'm not sure if this is actually the explanation, but this is a way by which I remember that it can cause abdominal pain as well. So there is no specific treatment. Frequent hand washing. So as I mentioned, it's a fecal oral transmission. So a child has to frequently wash their hands in order to avoid the disease. Avoiding close contact with people who are infected helps reduce the infection in the children. And we can see in here that there is this shallow grayish ulcer on the erythematous space. I think this is واضحة أكثر من الصورة اللي من قبل. So we can see the vesicles in here, the grayish, and the erythematous space surrounding it. What is this? I think we have discussed this in one of the PBL sessions, last block. So this is actually shingles. And shingles are actually caused by VZV virus. And VZV virus, varicella zoster virus, is a type or a member of the herpes of the herpes virus family, right? And this is actually this is the same type of virus that causes the chickenpox. A lot of us got the chickenpox when we were children, I think. And VZV is the causative agent for that specific for that specific disease. Now, how does it actually cause shingles eventually? It is that the usual understanding is that whenever you would have varicella zoster virus as a child, as chickenpox, the varicella zoster virus would eventually get transmitted to your get transmitted through the nerves, and it would remain latent, right? So it would remain latent in the dorsal ganglia, in the dorsal root, I believe, if I can recall correctly. Yeah, in the dorsal root ganglia. And eventually what would happen is that if you get older, if you become too old, or if you become مثلا immunocompromised due to one reason or another, and say, for example, you getting AIDS, لا سمح الله, or any other condition really that could compromise your immune health, this virus could eventually reactivate. And once it reactivates, again, it's going to travel through the nerves into the skin, and it could cause these lesions that are observed here. And this is an explanation for why the lesions occur in the dermatomal distribution. That is because you have the nerve that actually has these viruses inoculated in it, or remaining latent in it. And the viruses would travel into the dermatomal distribution of that nerve specifically. Now, again, let's read what's written here. So the herpes zoster virus caused by VZV infection, known as shingles in the elderly, and it's very painful, right? Unilateral vesicular eruption in a restricted dermatomal distribution. So this is actually very, very painful. Someone who might present to you, an elderly patient who had probably had gotten several infections when they were young, and experienced a lot of infections in their life, they would tell you that this is actually the most painful rash that they've ever gotten in their entire life. And so this is very painful rash, and thus you should treat it with opioids or any other treatments that could lessen the pain. So the patients frequently experience a prodrome of fever, pain, and malaise and headache. So it's an infection, once again, which precedes the vesicular dermatoma distribution by several days. So this is the prodrome. It's fever, pain, malaise, and headache. And then you could also see the herpes zoster. The rash eventually appears along the dermatomal distribution, as we have mentioned before, and the thoracic and the lumbar dermatomes are the most common involved sites of the herpes zoster. So usually it arises on the trunk rather on the peripheral sides of the body. The complications include ocular, neurologic, bacterial superinfection of the skin, and postherpetic neuralgia. So why would we see ocular and neurologic? We've mentioned that this is actually a virus that travels throughout the nerves. So once it actually reaches the upper part of the body, it could eventually result in compromisation of nerves that could supply the eyes. So ocular and neurologic complications could definitely be seen. And then the skin environment itself is compromised. So you can also see bacterial superinfection of the skin. And for postherpetic neuralgia, so what is this? This is actually when you have this severe pain persisting even after the rash disappears. And that is why sometimes you might continue the treatment after the rash disappears, because there is still this neuralgia. So the patient would continue taking opioids and acetaminophen even after the rash disappears. So the herpes zoster, the treatments include antiviral drugs, so acyclovir, famciclovir, valacyclovir, antivirals with corticosteroids if inflammation actually exists, and analgesics. Again, it's very painful, so opioids and acetaminophen. Okay, so moving on. So scabies, what is scabies? Scabies is basically known as al-jalb, and it's caused by mites. It's intensely pruritic. I think all of you might be familiar with this disease, since we often hear about it. It's intensely pruritic, highly contagious infestation of the skin itself, caused by Sarcoptes scabi, and it comes from the word sarx, which stands for the flesh, and scabies, which is to scratch, both of which are characteristics of the disease of scabies. So the scabies only affect the skin. Scabies causes extreme itching, which is usually worse at night. Why is it worse at night? It's because these mites, once the person has settled down and once they want to go to sleep, the body kind of becomes في حالة سكون نوعا ما. So these mites actually tend to travel and throughout the skin, and this causes the extreme itching. You might, in the presentation, you might see rashes, blisters might appear, so it's extremely pruritic, and that's why you might see rashes and blisters. Rashes and itching may last for 2 to 3 weeks, even after being treated. So why would you see the rash and the itching specifically? The itching, because the itching is actually caused by the allergenic antigens that are produced along the side of the travel of the mites. So the mites would travel, and you would see antigens that are produced by the immune system along the tracks of that of these mites, right? And these are the allergenic antigens that would eventually cause you to scratch your skin. So after you would treat these mites, the allergenic antigens would still remain there. So you would still have the rash and the itching. Clinical findings in between the fingers, right, along the head and the neck, nipple, elbow, wrist, waist, armpit, buttocks, penis, and shoulder. Um, there is no way to explain this. You would have to memorize it. And then the hands and the feet, especially in children. And in the adults, we usually see it in the genitals and the neck. How do scabies spread? Again, through skin-to-skin contact, by touching an infected person's items, through sexual contact, so it's an STI. And again, you should be cured before you actually resolve your daily activities with everyone surrounding you. And then this is a baby with the rash, and we've mentioned before that the usual presentation can include blisters, and something interesting about it is that it can present with burrows, and these burrows are kind of these linear lesions, right? And these linear lesions could be gray, and they're primarily caused by the scabies female mites that are traveling along this area specifically. And then the prevention, I think you can go through this by yourself. For the treatments, itching can make the infection worse. That is because you're basically making the mites travel through distant areas, and you're also, the allergenic antigens are also, you're spreading them throughout your whole skin, so it would definitely make your infection worse. People who are surrounding you should also take the medication, and everyone should take the medication so as to prevent it from so as to prevent the mites eventually. The head lice, right? This is also something that we're all familiar with. It's a small insect, and it lives on the human eye, and you can observe it with the naked eye. Head lice are transmitted through direct head-to-head contact, and there are different types of lice, and they're basically on different locations in the body. So there's the capitis, which is on the head. There's the corporis, which is on the body, and there's the pubis, right? These are all of the causative agents and where they specifically reside. And you could basically know where do they reside by by their last names. So capitis means head, and corporis means body, and pubis means pubic. So each of which would show you which area they really live in. And then the head lice could infect anyone, not just the children. So they're spread by families and friends, and head lice is unlikely to spread through objects such as chair backs, hats, and towels, and they do not carry the disease, right? So although there are some kind of diseases like rickettsia that can be caused by by lice, by body lice, however, the head lice specifically they do not usually carry diseases or infections. So I think this is the end for the for the second lecture of the skin. I'm not sure if I will actually explain the cutaneous neoplasms since they are self-explanatory. We haven't received the responses yet from the questionnaire for the most difficult lectures for week 4. So if cutaneous neoplasms comes up, I think I'll explain it. But for the time being, I'm not sure if I'll do. Inshallah, I hope everything was actually very clear, and I hope you guys understood everything. وسامحوني على الإطالة مرة كثير. Yeah, I wish you all good luck, and always remember to understand everything before you memorize it. Really, لو في شيء يعني أحب أقوله, it's like that medicine is not really about memorization, but more than understanding. And always make sure to understand something before you memorize it. And thank you all. Yeah.